Hello, everyone. My name is Dr. Susan Msadabwe, a clinical oncologist from the Cancer Disease Hospital in Zambia. I hope you have all enjoyed the very vibrant and educative sessions at this first ever Best of ASCO Africa. I would like to thank the organizers, sponsors, and ASCO for bringing this event to Africa. It is my privilege to present to you highlights of two abstracts that were presented in the Gynae Onc track at ASCO 2020. The first abstract I will discuss is Desktop 3, a study presented by Professor Dubois. This study was a multi-center randomized controlled phase 3 study evaluating the impact of secondary cytoreductive surgery in recurrent ovarian cancer. The background to this study is that surgery and medical treatment are cornerstones of ovarian cancer therapy. Though secondary cytoreductive surgery appears as an option for ovarian cancer patients, in guidelines, randomized data to guide decision-making has been lacking and therefore has been under debate for a very long time. As a result, several prospective randomized controlled phase 3 trials were initiated with different designs as well as patient selection. So Desktop 3 was based on two prior desktop studies that developed criteria for selecting patients who would benefit from cytoreductive surgery in relapsed disease. Desktop 3 included patients with relapsed ovarian cancer who had a good performance status, who had complete resection rates after first-line surgery and had ascites less than 500 mL. The primary endpoint was overall survival, and the secondary endpoints included progression-free survival, resection rate, treatment burden, which included morbidity and mortality. So 408 women were randomized to either cytoreductive surgery with maximum effort for complete resection, followed by a strong recommendation for platinum-based combination therapy or immediate platinum-based combination therapy with no surgery. Patient characteristics were similar in both arms with regard to age, stage, histology, prior treatment, and platinum-free interval. Some patients had received bevacizumab, which were similar in both arms, and very few in both arms had received PARP inhibitors, unlike in the current environment. In the surgery arm, macroscopic complete resection was achieved in 75% of all patients with low post-operative morbidity. In this slide, you can see that median overall survival was 53.7 months in the surgery arm versus 46 months in the no surgery arm, with a median overall survival gain of about 8 months, and this was statistically significant. Progression-free survival was also better in the surgery arm, which was 18.4 months versus 14 months in the no surgery arm. With regards to subgroup analysis, in the surgery arm, you can see that patients who had complete resection, that is in the red, had a much better median overall survival, exceeding 5 years, compared to only 28.8 months in those with residual disease. When you compare those who had complete resection to those who had no surgery, median overall survival was 62 months in the surgery arm versus 56 months in the no surgery arm. This again highlights the importance of complete resection in this cohort. Desktop 3 concluded that cytoreductive surgery for patients with a platinum-free interval of more than 6 months who are carefully selected improves overall survival and progression-free survival. So how does this apply to the African setting? As you know from the study, the importance of complete resection cannot be overemphasized. Whether we would have a pool of patients in Africa that would fit this stringent criteria is questionable. And also of note is surgery in this study was done in expert centers, which we might not have in Africa. However, the good thing is it then gives us options as we are the same area where medicines like bevacizumab and PARP inhibitors may not be within reach. The second study I'm going to present was conducted by Vincent Balaya et al. And looked at long-term oncologic safety of sentinel lymph node biopsy in early-stage cervical cancer. And this is actually survival data from CENTICO-1 and CENTICO-2 studies. Just a brief background on these studies. CENTICO-1 was a prospective multi-center study that assessed the diagnostic value of sentinel node biopsy in patients with early-stage cervical cancer. All patients underwent sentinel lymph node biopsy and systemic pelvic lymph node dissection. All patients who had bilateral negative sentinel lymph nodes had negative pelvic lymph node metastasis. CENTICO-2 trial was a prospective randomized multi-center trial that compared morbidity and quality of life of patients who underwent sentinel lymph node biopsy only versus pelvic lymphadenectomy. Patients with bilateral negative sentinel lymph node biopsy at frozen section were randomized to sentinel lymph node biopsy or sentinel lymph node biopsy plus pelvic lymph node dissection. The study emphasized that sentinel lymph node biopsy has less surgical morbidity and better quality of life than pelvic lymphadenectomy. However, as you know, systemic pelvic lymphadenectomy is the standard of care because there is paucity of data with regards to sentinel lymph node biopsy and especially survival data. Therefore, the goal of this study that was based on Sentinel-1 as well as Sentinel-2, CENTICO-2, was to compare disease-free survival and disease-specific survival in patients with early-stage cervical cancer who underwent bilateral sentinel lymph node biopsy only versus bilateral lymphadenectomy. So 345 patients were included between 2005 and 2012 from 30 oncologic centers in France. The inclusion criteria included patients who had early stage cervical cancer, which is stage 1A1 with lymphovascular space invasion to stage 2A1 according to figure 2018, had bilateral sentinel lymph nodes detected or bilateral pelvic lymphadenectomy and had negative nodes after ultrastaging or final pathology were included in this study. Those who had sentinel lymph node mapping that failed or those with positive nodes were excluded. After excluding patients that did not meet the criteria or were lost to follow-up, 259 patients met the inclusion criteria, and 87 of these were in the sentinel lymph node group and 172 in the pelvic lymphadenectomy group. Patient characteristics were similar in both groups. Most patients had minimally invasive surgery and the majority did not require any adjuvant treatment. Patients were also comparable with regards to tumor size, deep stromal invasion, lymphovascular space invasion, as well as other pathologic risk factors. Median follow-up was 53 months in the sentinel lymph node group and 46 months in the pelvic lymphadenectomy group. Nodal recurrences were similar in both groups, and so were patterns of failure, patterns of recurrence. There were 5 mortalities in the sentinel lymph node group and 4 in the pelvic lymphadenectomy group, which was not different. Median time to recurrence was 22 months in the sentinel lymph node group and 26 months in the pelvic lymphadenectomy group, which was not significant. Disease-free survival was also similar between the two groups of 85.1 in the sentinel lymph node group and 80.4 in the pelvic lymphadenectomy group. Again, there was no association of disease-free survival with type of lymph node staging, but disease-free survival, however, was affected by pathologic risk level. There was no difference in disease-specific survival between the two groups, being 90.8 in the sentinel lymph node group and 97.2 in the pelvic lymphadenectomy group. The study concluded that patients having negative sentinel lymph nodes or negative sentinel lymph nodes plus pelvic lymphadenectomy had similar survival, and that the most important prognostic factor is the risk assessment by SEDLIS criteria. The survival equivalence, however, needs to be confirmed by properly designed trials, of which some are now ongoing and are presented in this slide. In conclusion, currently in Africa, not many centers are conducting sentinel lymph node biopsies. But maybe by the time these results from the randomized studies are ready, the setting might have caught up. And in conclusion, I would like to congratulate the investigators of these 2 studies, and thank you for inviting me to speak at this event. Thank you.